energy, I need to eat. And so it promotes seek behavior. It is secreted from the stomach cell and it raises for the meals. And typically, when you eat, it goes down. Now, one of the problems what happens is after you have a weight loss, typically the level is higher, and that stimulates hungrier feeling and increase the chance of patient regaining weight. And that's part of what we call metabolic adaptations. Your body will adapt and actually will make you eat more. So it's kind of your body fighting you not to lose weight. So that's one major driver. Another one is GLP-1, which is you all know. So already it's a hormone secreted from the L cells in response to food intake. And it has many effects, including, of course, stimulating insulin secretion in glucose-dependent matter, suppression of glucagon. It also decreases gastric emptying. Now, you may say, well, like when we use it for diabetic, that already patient with diabetes will have gastroparesis. Actually, the majority of diabetic have a faster stomach, and so they tend to feel hungry sooner, and they will eat again. So that's one of the mechanism. It's going to reduce the food intake and the frequency. And so that's one also of the factor that help with satiety. Another one is peptide Y, which is again co-secreted with the GLP-1 in response to food intake. And again, it reinforces the satiety. It works synergistically with the GLP-1. It again suppresses the appetite after meals. But one thing we have to remember that when we are observed, there is some kind of a blunted response, similar to how we can have, for example, if you want to call it the leptin resistance that we see in patients with obesity. And so the both of them work synergistically to increase satiety, reduce the feeling of hungry, and reduce food intake. Now, GIP again is secreted from the K cells, primary in duodenum, proximal jejunum. But one thing we have to understand, it's somewhat similar in the sense of it's secreted in response to food intake, but it has a lot of other effects. One of them actually increased lipolysis. Now that sounds contradictory, but actually what it does many other factors, including when you have it in a synergistic effect with GLP-1, it works differently. So it's one of them, it's lead to the white tissue to be more of a brown tissue, so a better metabolically active tissue, and it reduced the inflammation, and then it increased lipolysis. So it's actually is going to improve in a way in weight loss and reduce the food intake. So the effect of the GIP by itself may be a little bit different than when you have it in sync with the GLP-1, and we already have one product that have activation effect on both receptors. Insulin has been alluded to again. When we eat food, your insulin goes up, and that actually goes to the brain and reduce your food intake. But of course, that in a sense of a normal physiology. When you are an insulin resistant, that's a little bit disrupted. And that's one of the factor of this, if you want to call it a vicious cycle, patient continue to have loss of the effect of the insulin suppression of the hunger. And so that's also will increase patient eating and worsen the condition that they already have. Glucagon. Now we all know glucagon secreted and it raises the glucose and suppress the chance of getting hypoglycemia, but it has other effects. So again, it's secreted after a food, but typically what's going to do is going to go and have a direct effect on the brain, not directly as the insulin does, but through the effect on the liver and stimulation of the vagal nerve. So it's a little bit roundabout thing. It's again, it activates brown adipose tissue, and so that's what's similar to what you see when you have GLP-1 and GIP. And we're going to have later agonists for the GLP-1, GIP, and glucagon, and it enhances also fatty acid oxidation. What also? So when you look at it, you can see this is part of the hormones related to the gut itself, and we're going to go over other signals. But you have to understand that if there's you can have a problem in the gut itself. So any problem related to inflammation, sometimes even possible to antibiotics exposure that change the microbiota. Anything that can affect the vagal transmission could also affect your hunger and weight. And also any effect on the brain. You can see sometimes patients who had brain surgery or radiation that they have uncontrolled hunger and they have excessive weight gain. So any of abnormality across any of those points can have an effect on weight gain and hunger and satiety. One thing to go over is the fact is how fast and slow the stomach moves. So of course, as I mentioned before, the faster stomach is going to cause, again, the feeling to get hungry sooner, and the slower stomach is different. And that's one of the reasons that when you use a GLP-1, it has an effect on that. There are things we can do in life and in the diet to help with it. You can try, of course, to have a protein and fat, and that a little bit slow down the movement of the stomach. And you can try to eat, for example, the vegetable and the protein prior to the carbohydrate. And that also can reduce the swings in the glucose and insulin level that can happen after meals. And that will have some effect on patient glucose, insulin level, and hunger post meal. And so you put all that together and you mix it with this microbiota. Now, again, microbiota, again, as I mentioned, trillions of cells or bacteria and then interact. And a different mix of bacteria can increase the risk of obesity or type 1 or type 2 or many other autoimmune condition. And there's a lot of data to link the microbiota even to um, depression, to autism, to schizophrenia. And there's also mainly, as you say, a feedback system. So the microbiota can affect the mental status, but the mental status also can affect the bacteria. And there's a definition called dysbiosis, which is you have an altered microbiome that can relate or cause mainly more of weight gain and metabolic syndrome. And what can cause dysbiosis? Western diet, McDonald's. So diet is important for the microbiome. Now, I'll give you an example how important is this. There was one study done in University of Washington, St. Louis, and what they did is actually they have identical twin, same genes. You expect the same BMI, but you're going to have sometimes identical twin, one is thin, one overweight. So what they did take the flora or the microbiota from the overweight twin and from the thin twin, and they mix it with the chow for the mice. And what happened is the mice who had mixed chow that's taken from the overweight twin become overweight, and the other mice continue to be thin. So what I'm trying to say that even though they were given the same food, they had changed because their bacteria had changed. So I think this is very promising future that not only we can use medication and injections to help with weight loss, we may be in the future able to do something to change the microbiota and help patients to treat their condition, albeit inflammation and any sickness and any autoimmune disease and prevention of type 1. This is a very big field that's still not well understood. So what we eat can affect this microbiota, can affect the hormone. Of course, you eat protein, you can stimulate GLP-1, PYY, carbohydrate again. You want to avoid refined carbs because that could change the microbiota to a bad one. Fat cells also will delay satiety, will stimulate CCK, will stimulate GIP, will slow gastric emptying. Now, the what we eat as macronutrient is so important, and it can start even at infancy. So if we look at kids who get breastfeeding throughout the period, they are going to have, in a way, different microflora or microbiota, and they're going to have a change of increased leptin, decreased ghrelin that actually reduce their food intake and lead to a healthier child. Where if a child get introduced to formula, they're going to have different bacteria, different microbiota, and different hormonal environment that can lead to weight gain in the infancy, in the childhood. Even if there was complementary formula given in formula, that still will have a negative effect on the child. So having a breastfeeding will be very important, not only to transmit immunoglobulin and reduce infection. Actually, it reduces the chance, as it seems, of a child getting to have overweight and diabetes and so on. And different food macronutrient will affect differently in the microbiota. It's just an examples. Um, I don't know those bacteria myself, to be frank, but the food is very important factor, one of the factors that will change the microbiota, and you want to avoid change your bacteria in the gut to a bad complex or dysbiosis, which again lead to more obesity and increased hunger. Now we come to the hypothalamus, which is again the gatekeeper. It's the one that control the food. So you have the signal from the, we talk about the hormone, the stomach, the hormones, the signal through the vagal. Then it comes to the hypothalamus. But the hypothalamus itself is quite complex organ. Not only there is communication between the gut, within the hypothalamus, you have multiple nuclei. So you have um, the arcuate nucleus, which is the main one. And then in the lateral hypothalamus, it tends to be the hunger center. The medial is more of satiety center. Now, in this graph is very confusing, but you have a lot of hormones that will increase satiety and fullness. Of course, leptin will have an effect on it. POMC will have an effect on it. There's cocaine and amphetamine regulated transcript that also will reduce the food intake, peptide Y. But also, you have things that increase the hunger that also will work in a different mechanism. But you can see how complex this network. So not only you have signals from the intestine, you have signals that come through the vagal nerve, you have the microbiota, and within the hypothalamus, there's a communication between the different nuclei in the hypothalamus. There's communication between the subcortical area and the hypothalamus, and there's communication between the hypothalamus itself and mainly the reward system. So again, the hypothalamus is more of the metabolic need. You know, I need to eat to survive, if you want to call it. But again, you can get disruption in it and you end up by overeating. But the hedonic hunger is different. It's reward, it's pleasure. We are a little bit different than animal because we can continue to eat even if we're full, if we like something. Of course, if we're stressed, we didn't sleep well, we're likely to eat highly palatable food like fat, sugar, salt. And that's part of the problem. And it becomes this kind of a vicious cycle because you like the feeling, you like the dopamine surge, and reinforce the same habit that, you know, today actually I came, you know, I had a patient who came and she wanted to start a treatment, but her main issue is stress. She's so stressed. She has a lot of responsibility being a single mother. And she wants to take a medication to decrease her food intake. But her main issue is she come home at 8, 9 p.m. after work, and she has to eat. And of course, typically you're going to overeat and eat all the kind of bad things. Now, of course, we discussed the fact that maybe we need to change in a way or any factors to help her environment where she doesn't need to work that long or something to help with her able to deal with stress and reduce her stress and load because that also a factor in the obesity. And then on top of it, of course, as Dr. Well mentioned, the insomnia is a big factor. Now, why some patients are hungrier or heavier or so, beside the lifestyle we live in, of course, which is important, it doesn't mean that if we're overweight, it's never our mistake. But there's something that's hormonal difference between us, including our baseline GLP-1, our leptin sensitivity, there's genetic variability between us, and there's a difference in the microbiome. And you all know some people who can eat anything and they're very thin. And he was like, why is this? Well, there is a difference between the people. So not everybody who's overweight slash obese, it's their mistake, but it doesn't mean we don't inform or enforce healthy lifestyle because we know this also will have an effect not only on the calorie intake, it has an effect actually on the bacteria in your gut or microbiota. So when we lose weight, again, there's change in the hormone. increasing your ghrelin, drop in the leptin, and that's one of the factors that make you
عفوا دكتور
weak.
جلال, just you have 5 minutes. Thank you.
Sure. And typically you have a drop in the metabolic rate, which is actually make it worse to be ill. So when a patient tell you that sometimes I cannot control my eating, that is correct. It's not necessary, again, their mistake. And there are things we can do to help patient. It's, again, we have to emphasize that this is a chronic condition and it's not always your mistake. Now, it is a signal. It's not a failure on the patient behalf. And we have to, make patient understand this fact. That's, they should not blame themselves on everything. We have to try to help them with their struggle and try to address what we can do to treat or address the hunger pathway that make them fail on their trial to lose weight or maintain the weight loss. Now, of course, exercise is very important. We do have agents that help with weight loss, either GLP-1 agonists such as semaglutide. Again, we talked about GLP-1. We have dual agonists, which is tirzepatide. Later, we're going to even have triple agonists, and there's different agonists that's been in the market that will be coming over time. There are also amylin. I did not touch on amylin. That's a whole different story. So to try to summarize this, hunger is biology. It's regulated by hormone. There's multiple pathways. Um, Post-weight loss hunger is predictable. We have things to help patients fight this hunger. This may take years, and that's one thing to understand. The hypothalamus may take 6 to 8 years to readjust maybe to the new weight. We don't know. We do have pharmacotherapy that can target this axis directly. And, we have to understand this and treat the patient in that perspective and try to see what we can do to help them in the process. And thank you very much.
Thank you, Dr. Jalal, for this. Now we are hosting Dr. Hisham Harb on metabolic adaptation and weight regain, why diets fail. Dr. Hisham Harb is a consultant endocrinologist and medical director at EndoCare Clinic in Dubai. He's a distinguished consultant endocrinologist at Emirates Hospital and medical director of EndoCare Clinic in Dubai, a fellow of Royal Australian College of Physicians, and a member of the UK Royal Colleges of Physicians. He completed a specialized fellowship in obesity and metabolic medicine in Melbourne. He brings extensive, long-standing expertise in managing obesity and endocrine disorders, with significant career spanning both in Australia and in GCC region. Dr. Hisham, the floor is yours.
Adaptation and weight regain and why diets fail. And this is my disclosure.
Dr.
And
Hisham, I cannot hear you. Can
learning outcomes.
Dr. Hisham?
We start to understand together the energy balance, why energy exponentially falls after a
Dr. Hisham,
diet plans, and why weight regain happens after weight loss. And we try to understand the metabolic adaptation and what are the hormonal drivers for of weight regain, and what are the hormonal drivers for of weight regain, and we will go to the set point theory before conclusion. Let me start with the basic physiology. Actually, when we attempt any diet plan, we try to lower the calorie intake. This is what we call calorie intake. This is what we call it calorie deficit. And if you see here, when you lower the calorie intake from 2,000 to 1,500, that's possible within a few days. And that may continue for a year if you like. But what do you expect with the energy exponential in the response of that calorie deficit? If you look at mathematics and physics, you can do it calories in, calories out equation. then you say, okay, now I'm lowering the calories intake by 500 calories. Then the body would respond to that by using the storage of energy to compensate. But in biology, that doesn't happen. In biology, whenever we lower the calories, if you see here the blue line, then the orange line is the energy expenditure over time. Then what happened? We start consuming less here over time. We spend less, the energy expenditure were less. I always explain it to my patient and try always to link that clinically. If your income dropped by half, then you will reduce your spend. Otherwise, you will be in financial crisis and might end up in the jail. Then this is the physiology. Always there is a protection from energy deficit, and that's why the plateau will happen at some stage. Now, when we lose weight, usually we don't lose only fat. Physiologically, we lose muscle, bones. That's what we call it, fat-free mass or lean body mass. Then after that stage, the metabolic adaptation will happen. And this is very critical point. The energy expenditure drops more than expected for the new body composition. I will explain that later. And that makes weight maintenance is very difficult. Now, this energy deficit would lead to reduction in the energy expenditure. How that happened? And that's driven by two major pathways. The first one is the neuroendocrine, and the other one is the peripheral effects. Now, many changes would happen, like reduction of leptin secretion, and that falls disproportionately. Means if you reduce 100 calories, the leptin reduction will be more than expected. The T3, which is very important hormone, also would go down, but that's functional. If you check your thyroid function test, that will be normal. Now, there is less stimulation for lipolysis or breaking down the fat, and our hunger hormone, the ghrelin, will go up, and there will be changing of the behaviors of eating, like you start feeling more hungry, craving sweets, craving calorie, be changing of the behaviors of eating, like you start feeling more hungry, craving sweets, craving calorie dense food. And what happened to the resting metabolic rate? Resting metabolic rate, the amount of calories that we require for essential physiological functions, like respiration, for example, cardiac function, brain function, that also goes down by 5 to 15%, and this is more than expected. And also, there's a reduction in what we call it non-exercise activity thermogenesis, means the energy expenditure from simple function, which is not a deliberate exercise, like, for example, cooking, moving around in the house, or cleaning, desk job, and that's unknowingly moving less, then you will feel that you're lazy more than usual. Then the muscle efficiency increases, then less energy will be used to finish the same work. All these changes will happen just to save energy. And there is a classic work by Kevin D. Hall demonstrates that the gap between the predicted and actual energy expenditure can be 100 to 300 calories per day. Then what we predict is not the actual energy expenditure for. Now, when we do the calorie deficit, we lose weight and we may lose 5, 10, 15 kilograms, yes, but the day that you stop that calorie deficit, what happened? Then we return to the previous intake. Then our intake goes back up quickly, for example, from 1,000 calories to 2,200 calories. But keep it in mind, the energy expenditure is still suppressed, and that will be suppressed for longer periods. And now you have a positive energy balance, then you will gain weight quickly. This is what we call it metabolic adaptation. Then the energy expenditure, as I explained earlier, drops beyond the expected level, and that persists for a long time. Let's see here, for example, if you lose 10 kilograms, what you expect that your energy expenditure goes down to 1,800 calories per day. This is what you expect. But the actual reduction of the energy expenditure, it's 1,500. And there's a difference around 300 between what you predict and what's the actual energy expenditure. Then that makes the weight regain much easier, and that makes the continuation of weight loss less likely. And this is what we call it plateau. Now, behind all this, pictures that I explained, there are hormonal drivers. I had the pleasure to work with Dr. Sumithran and Professor Joe Proietti in Australia and Austin Health. When we studied the hormonal changes when we lose weight, what happened? Why we stop losing weight at some stage and we hit plateau, and why we regain weight at some stage. Then there are significant hormonal changes will happen, and that may persist for at least 12 months, at least. It might be 2 or 3 or 4 years. And after that, the weight stabilizes. Then, whenever you try to lose weight, you are fighting your biology. Then, what happened to the leptin, for example? It decreases around 40%. Grilling increases 40% to increase the hunger and the food noise. Other hormones like PYY and GLP-1, this is the most common one that we know it, reduces by 25%. Then these hormonal changes are behind what we call it metabolic adaptation, and I will explain the function of every one of these hormones in details. Now, leptin is a major signal for energy deficiency secreted by the fat cells, adipocytes. And as I explained before, it falls disproportionately with weight loss. It's more than expected. Then there is a signal going to the hypothalamus to say, okay, now the energy stores are low. This is alarming for the body. Then what's happened? Increased hunger, reduction of the energy expenditure, and increase the drive for reward value of food. This is the central driver of what we call it defense of body weight. And this is the first hormone. The second one is ghrelin. Ghrelin is a hunger hormone produced in the stomach, rises after weight loss, as I explained. And any kind of diet, the ghrelin will go up, and you start feeling more hungry. Then we have more tendency to initiate meals and try to always seek for food-seeking behavior, and we prefer food-seeking behavior, and we prefer calorie-dense foods. We go more to fatty food, dense food, carbohydrate, and the patients often describe it in the clinic as, "Oh, doctor, I'm hungry all the time now." Why? Because of the ghrelin. Now, PYY is a satiety hormone. It's similar to the GLP and leptin, but this is the hormone comes from the distal gut cells. Normally rises after meals, and after weight loss, what happened? There's a blunted repulse. Then you start feeling that the meals are less satisfying. You eat, but you not feel full. Then you need to eat more. When this hormone goes down. Now, GLP-1, everybody know it now because of the GLP-1 receptor agonists. Then it comes from the distal gut cells. Usually enhances satiety. You feel full, and that reduces the gastric emptying also. That's why it's good for diabetes management. Then after weight loss, what happens? Reduction in the signaling, then weaker meal termination. There's no signal will go to the brain to say, okay, now stop eating. You keep eating. If you finish your dinner, then there is a delicious dessert. You will be able to do that because your GLP-1 is less than expected. And that's why, to keep it a little bit clinically related, GLP-1 receptor agonists inhibit the metabolic adaptation. And that's why people keep losing weight, and it's not easy to hit plateau in a short period of time. Now, what happened over time? If you see this from the famous look ahead study, phase number one, maybe from you start till 12 months, there will be a significant drop of the weight. You may lose 10 kilos or 15 kilos or whatever, and that's driven by the calorie deficit, by glycogen depletion, and early water loss. That's why most of our patients will say, okay, I lost 6 kilos in the first month. That's not always fat. There's a water loss, and this is the first thing that you see when people lose weight. Then phase number two, you start plateauing. Then weight loss slows despite continued efforts. And that's why people start to be disappointed and frustrated. I'm doing the same efforts, the same diets that the dietitian advised me, but I'm stopped losing weight. And that's what reflects the metabolic adaptation. Phase number three, which may continue for 3 or 5 years, there will be a gradual weight regain. And it might be partial or complete weight regain. You go back to the same weight that you started with, and over time that stabilizes. Then this is the natural response of the body, which is a defending mechanism to save energy. I will go to the important slide, which is the set point theory. In our hypothalamus, there is a center that is called homeostatic center. The only job of that center is to protect us from energy deficit. Whenever you start lowering your calorie intake, there will be a signal going there to say, this person trying to lose his storage of energy, which is the fat. Then we'll start the defending mechanism through the hormones that I said. Then it's best described as settling point, not only set point. It's not a specific number. It might be range, let's say, between 100 and 105. And remember that our brain always defends strongly for the highest weight ever that you reached. Why that specific weight? Most likely that's driven genetically and biologically. Then this settling point influenced by environment, any environmental changes like high stress level, lack of sleep, lack of physical activity, increased calorie intake, cravings, food noise, all that would help to increase the set point. And for the brain, that's fantastic, no issues. But if you try to reduce your calorie intake and lose weight, then the brain will be very upset and will start doing whatever possible to stop you from doing that. Then there's a weak defense for the lower threshold and strong defense for the higher threshold. Then the $1 million question, can we change the set point? Can we shift this set point? And there's no clear answer for that, but maybe sustained interventions by medications like GLP-1 receptor agonists and other what we call them nutrient stimulating hormones that may help in shifting the set point over time, but that may take years. That's why long-term therapy is very important when you deal with obesity. Now, I will conclude my um, presentation with this. My um, presentation with this AI generated slide about the set point theory, and I tried to link that clinically a little bit. Then this is the set point. There's upper threshold and there is lower threshold. Whenever you try to lose weight, then up and down. This is what we call it yo-yo effect. You lower the calorie intake, you lose weight a little bit, then you plateau, then you go up again because of whatever I explained before and mentioned here already, leptin, insulin, ghrelin, PYY, GLP, this hormonal driver. Then when we lose weight, many things will be triggered. And as I said before, energy expenditure, reduced resting metabolic rate, and thermic effect of food, increased appetite and hunger. And there's many changes, which is like new behavioral changes like food cravings, reduced satiety, and increased preoccupation with food, always thinking about food. And the result will be positive energy balance and the gradual regain toward the set point. Then the typical trajectory, loss and regain toward set point. There's a set point like a thermostat. If you don't change that temperature on the thermostat purposely, then the temperature automatically will go to that degree. Then here, what happened? When you start to lose weight and intentional weight loss, it goes down, then there's a compensatory responses to be activated, and that lead to a gradual weight regain, then again going to the set point. Then, sorry for that, then what's the clinical implication for that? Then weight regain is biologically driven. It's not a lack of willpower. Tell your patient, whenever you try to lose weight, you fight your biology. It's not about personal responsibility. It's not about willpower. Lifestyle changes are very important, but with limited efficacy, and that improves the quality of weight management and quality of obesity management, but not to lose weight and maintain it. Long-term strategies, as I mentioned, are needed,
Thank you,
and
Dr.
that will
Jalal,
be
for this
multidisciplinary.
talk. Now we go
Pharmacotherapy, of
back to
course, is very important these
Dr.
days, and this
Hisham.
is the
Thank you so
only
much. Now
way
we
I
go back
believe on
to
the long
Dr.
run
Jalal
that will
Nafash to talk
change the
about
set point
Fundayo,
or
a
shift
new
the set
start,
point.
the oral era, symposium by Eli Lilly. As we talk, that Dr. Jalal is a consultant physician and endocrinologist in Dubai Diabetes Center. Dr. Jalal, the floor is yours.
I'll put the timer to make sure I don't exceed my time. So I'm going to go over Fondayo or orforglipron tablet. It, it's a new product. Just got approved in UAE one day after the FDA approval. So we're really the first country after the US that got the medication started. And so what we're going to go over is again, we start with the disclaimer. We're going to go over the etiology, the drug, how it works, and the efficacy data. So one thing we have to remember, and that's been alluded to in many lectures, that hunger and satiety, again, it's a complex issue. One of the signals is the GLP-1 and GIP and so on. But there is a change in the hunger and satiety that occur on those with obesity. And it's a chronic condition that sometimes it make it difficult for the patient to lose weight. And even when they lose weight and there is a metabolic adaptation, they find it very hard to maintain the weight loss. Statistically, 80% of the patients who lose weight will regain the weight. One things that we can help ourselves not to regain the weight is make sure that in the process of weight loss, that we are exercising and doing more of resistance training. I think Adam mentioned that will help you maintain muscle so you don't lose muscle during the weight loss phase, and then maintain the exercise as typically the target to maintain weight loss run about 200 to 280 minutes a week of moderate intensity exercise, specifically resistance training. Now, why do we care about obesity? Because it's associated with many things. It's increased risk of type 2 diabetes. Actually, every time you gain about 4 or 5% of the weight, your risk of diabetes double. And when you look, for example, on the North Health study, which we're looking at BMI of 22 versus BMI of 35, you have almost 3,000% more risk of type 2 diabetes. There's increased risk of sleep apnea. And, that's why some of the medication we have is approved to treat obstructive sleep apnea. There's increased risk of hypertension, heart failure, asthma, osteoarthritis. And that's going to be one of the indication of the weight loss medication. Chronic kidney disease increase and risk of many cancers, including not limited to liver cancer, pancreatic cancer, breast cancer, and so on. So we have to understand that there's over 200 complication of obesity, and so when we treat obesity, we're not treating just the weight or the how the person look at. And I think that's one of the reasons that the guidelines, even on insurance, will change most likely in the near future to cover individual with weight gain that have complication. Now, again, it's going to be a complex regimen and some patient will get reimbursed. But the idea is saying if you have a problem with the weight associated with the complication, they're going to be coverage to help patient dealing with obesity. Now, how much weight loss we need to do to get any benefit? Now, if you lose only 5%, you can reduce the risk of getting diabetes by maybe 50%. But to get the remission, you need about 15% weight loss. There is one study where you can see that those who achieve 15-kilogram weight loss really had much higher chance of mainly, quote unquote, if you want to call it cure. You need 5 to 10% to have a reduction in osteoarthritis. Obstructive sleep apnea is also reduced. Now, the high blood pressure and high cholesterol will improve and will continue to improve with more and more weight loss. Now, from a MASLD, so the earlier stage of fatty liver, if you want to call it, even 5 to 10% is quite significant benefit. But when you arrive to F3, F4, and you get MASH, then, sorry, F3, then you need more significant weight loss. Now, with polycystic ovarian, of course, weight loss will be beneficial, and actually, people become more fertile as they lose weight. So, we need to advise people when they're on weight loss program, medical weight loss program, that they need to try to make sure they don't get pregnant or use protective. So if we start, for example, with a patient, and this is kind of the typical patient you see that live with overweight, have a BMI 27 to 30. Now, why do we use this BMI? Because all the trials done this way. Now, I don't necessarily think that you have to, again, this is a regulated presentation, but this is the way it is. But you have to understand you need to look at the patient individualized. And if you're looking about how important to treat a patient, maybe if I have a patient with BMI of 26.5, maybe I'll treat them if they have multiple complication. You may have a patient with BMI of 29, I may not treat if they don't have any complication. So I think you have to be aggressive, especially if the weight is causing complication. You have to understand there's something called healthy obese, which is more common in the white population, less common in the Asian population. And so when you start with a patient like this case, who is 40 years old, weight 84, height 167, BMI of 30, who have already a complication, including high blood pressure and high cholesterol. And typically what you see on those patients is they know they have a problem and they try to do things and they may lose and gain. Now, one thing you always have to do on question a patient who lose weight, typically I ask them, how many times did you lose and regain 5 kilograms? Now, why do I use the number of 5 kilograms? Because it's kind of the 5-6%, which is clinically important, where a lot of patients may lose weight, and of course they lose fat and lean muscle because typically they're not exercising, and then they regain mainly fat, and that's also one of the factors why they have lower metabolic rate at the same weight. So if patient done multiple times where they lose and regain, it sometimes become even harder for them to lose weight anymore. And typically what you see like this patient, she started 2 years ago with BMI of 29, and then she started to gain more weight, and she started to have complication. And then now she is frustrated. She wants to do something. Now, you can say, you know what? I'll wait till maybe you become diabetic, but you can wait a few years. But then at that time, she'll be the diabetic, hypertensive, hyperlipidemic. So the question is, do I treat the condition that caused all this complication, or do I do symptomatic treatment, i.e., I wait till the blood pressure happen and then I give blood pressure medication. Then I'll wait till the cholesterol goes up. Then I give cholesterol medication. Then I wait for diabetes. Then I give diabetes. Or you can say logically, let me try to treat the condition which causing all those complications. And so this is where we're going to go over the Fondayo. So what's Fondayo? Well, Fondayo it's a new GLP-1, simple administration. You give it once a day, anytime, with or without food or water restriction. So you can take it anytime, it doesn't matter, once in a 24-hour. Now, GLP-1, we've talked about it. So again, it stimulates insulin secretion, suppress glucagon, increase satiety, slow down the gut, and it has a degree of benefit on metabolic rate and energy balance. And so by using this new non-peptide structure, so why is that important? It's non-peptide because it doesn't get degraded in the stomach and it doesn't get breakdown, and you don't need to do anything to improve absorption. You don't need any absorption enhancer, and it has very good bioavailability. Now, the major study that it's called ATTAIN-1 trials, and ATTAIN-1 is 72-year-old multi-center parallel multinational study, and they typically, as all the weight loss trials, they look at patients with BMI of 30 or above, or 27 with a complication of related to obesity. Now, patients started either on placebo once daily. They started Fondayo, 0.8 milligram daily for 4 weeks or 1 month, then 2.5, then 5.5, and they stayed on the 5.5. There's a Fondayo 9 milligram arm when they started again 0.8, 2.5, 5, 9. And so from the fourth month, they're on 9 milligram. And then Fondayo 17.2 milligram arm, they started 0.8, 2.5, 5, 5, 9, 14.5, 17.2. The numbers, I know it's typically we don't see medication numbers around the zero point 0.5 milligram and zero point 0.2, but this is the design of the trial in a way. And so they were randomized and they had adjunct to healthy lifestyle and physical activity. Now, by using Fondayo or orforglipron, what happened? Now, number one, when you look at the weight loss, those who did placebo have a weight loss of 0.9%. With the 5.5 milligram, there was 7.8% reduction in the weight. Fondayo 9 milligram was 9.3% reduction, and the 17.2 was 12.4% reduction. Now, again, so what that means that if you have a patient who fit the criteria, who has a BMI of 30 above, 27 complication, using this medication as one pill daily will achieve minimally up to 12.4% weight loss. Now, saying that, you have to understand that there's in the GLP-1, there's heterogeneity of the response to the weight. And actually, in all weight loss trials, there's heterogeneity whatever you do. There are a super responder, there are average responder, and there is non-responder. And so if you look at what the percentage of patients who lost 5% or more in the 17.2 milligram arm was 77%. Now, why some patients don't lose more? Nobody knows. There's still now no way to predict who's going to respond and who's going to respond more. Even patients who get nausea, and you assume if they get nausea, they will eat less and lose more weight. It's not really the case. And so really, you don't have a way to know the response till you treat the patient. When you look at the percentage of patients who lost 10% or more, 60%, who lost 15% is 39%. So I think this is nice to present to the patient. So if a patient comes to you and they'll ask you, how much I'm going to lose with it, say the average is 12.4%, you ought to lose 10% is 60% mainly, 15%, 39%. So again, we don't know what you're going to do. We're going to try and see how you respond. Now, if we study the same population, and this is look at subgroup of 171 patients, and they included the data of 140 patients who did the DEXA at the beginning of the trial and the end of the 72, and you can see that there was significant reduction in the total fat loss. There is an 8% reduction in lean mass, but you have to understand that lean mass doesn't mean necessarily muscle, because lean mass will include fluid, soft tissue, and even the fat in the muscle. You have to understand that we have ectopic fat in the muscle. So this is not a necessary 8% muscle loss, number one. And number two, if you exercise, as I mentioned earlier, and you maintain adequate protein intake, somewhere between 1 to 1.5 grams per kilogram, you are not going to lose muscle. And there was a significant 34% reduction in the visceral fat. So that's quite significant. Now, the other thing, what kind of change in the waist? Typically, if you use the Fondio 17.2, you get about 11 centimeter drop in the waist, 9 centimeter in the 9 milligram, 7.5 centimeter in the 5.5. So you can tell a patient, don't buy pants, wait, and most likely, if you wear jeans of, let's say, 38, most likely the waist will be 33, 34. Now, of course, that's the average drop. Those who lose more weight, that are going to lose more waste, of course. So if you try to look at the data and what kind of effect I see in all parametabolic parameters, you get reduction in the systolic blood pressure, you have a reduction in high sensitive CRP, you have a reduction in the LDL, you have a reduction, as we mentioned, in the waist circumference, there's an reduction in triglyceride, and there is improvement in HDL. So even if you have a patient with elevation in triglyceride, sometimes, because you have to remember, even if you give them prescription fish oil or fenofibrate, typically the average reduction 30% or so, you may actually get a similar reduction just by using weight loss agent, and you don't need to actually treat the symptoms, i.e. the high triglyceride. Now, what's about adverse event? Now, again, as we know, the major adverse event is gastrointestinal. So nausea tend to run around 30%. Constipation, 20%, diarrhea, about 20% to 22%, vomiting, dyspepsia. Now, there are things we can do to help with it, and we're going to go over that. The majority of GI side effects were mild and moderate in severity. Now, there are cases of mild pancreatitis. In the publication, there is even two cases that, for me, when looking at it, it's not clear even for me, it's actually pancreatitis. But irrespectively, they were very mild case, self-resolved. I think three of the patients were admitted, or four, and one was not even admitted. How do we start? Well, we start, as we mentioned, with 0.8 milligram. You do it for 30 days, then you go to 2.5 milligram, you do it for 30 days. Then you're going to see what I need to achieve the treatment target. And you discuss with the patient, you can go to 5.5 milligram. And then you decide, I'm going to go to 9, maybe 14.5, and maybe 17.2. And that based on how patient respond, how is his symptoms, and where are we close to the target. So, I mean, if I have a patient who's doing very well, at 9 milligram, I may not push the dose. If they're tolerating well, they're losing well weight nicely, I'm not in a race to push their weight fast. And that's one thing we have to explain to patient, that we're not aiming to make you lose weight fast. I want you to lose it slower if I can. I want you to exercise. I want to avoid any muscle loss. I want it to be as sustainable as possible, because that's the major problem. We don't only want them to lose weight, we need them to maintain what they achieve. So how to take it? You can take it anytime, as I mentioned. Food, water does not interfere, so there's no restriction in that part. If you miss a pill, try to take it in the same day. If you miss the whole day, the next day you don't take two, you just take one. So do not exceed one per day. You swallow it, don't chew it, don't split it, don't crush it, and you keep it in the original packaging. Now, things you can do to try to help with the GI symptoms, again, it gets better over time. Eat multiple small meals rather than one big meal. When you're not hungry, and stop eating, you don't have to keep eating until you feel overfull. So once you're not hungry, I would say maybe it's time to stop. And, sometimes you're just fine. You don't have to eat more. Don't eat very sweet, spicy, fatty food, because that could worsen the symptoms. In case you get constipation, make sure you have an increase in the dietary fiber, or you can treat and use any of the constipation medication. Make sure that you are very well hydrated and you're drinking 6 to 8 cups of water daily. So, what did you get with this drug? We have one pill a day, expected side effect, like any other studies where they have the nausea about 30%, that you can take anytime. There's significant weight loss, as we mentioned, 12.4%, waist reduction, 11.1 centimeter, reduction in the triglyceride, blood pressure, and reduction in the high sensitive CRP. And the safety, as we mentioned, similar to other GLP-1. And I'll stop at this point for the Q&A.
Thanks, Dr. Jalal, for this amazing talk. Now we take the Q&A session as a panel discussion. You can write your questions there. Um, Dr. Jalal, we have a question. How do we make the transition from Monjaro to Fundayo if patient is asking for it?
All right. So uh, there is a study called Attain Sustain, where mainly you transition people. Now, typically, you're going to transition per label, so you start with a lower dose and you titrate up. I personally, if somebody doing well, I don't transition. I just keep them on the same treatment. So if they're doing well with tirzepatide, I reduce to the lowest dose they need to maintain the weight loss. Now, in the transition trial, those who were taking semaglutide and switch to Fondayo, maintain the weight loss, but those who were on tirzepatide and switch to Fondayo actually gained 4 or 5 kilograms. So if I have somebody who's taking tirzepatide and they're doing fine, change them personally. Now again, if patient does not want to do injection, then I'll go to oral tablets in that sense. So there is a population that I'm going to use Fondayo for, and there is a population I'm going to use, tirzepatide for. And I think part of it is what the patient preference, their tolerance to medication, and the target you're trying to achieve.
Thank you, Dr. Jalal. I have a question for Dr. Wael. Dr. Wael, what are the biggest misconceptions about obesity management at primary care that primary care physicians should actively address with patients?
Thank you for that question. I think one of the things that I've encountered with patients that, and I mentioned in my presentation, that the fact that they're cheating, there is still that ongoing belief that people are ashamed of saying that I'm on Manjaro. I've had many patients, and I'm sure yourself and my colleagues might have had the similar experience where patients tell me that I do not want to tell anyone, I don't talk about it. And actually, they tend to whisper it when they say, oh, I'm taking this injection, but I don't want to talk about it. Another misconception, if I may say, it's kind of like the risk, unfortunately, of association with thyroid cancer. I think this is still a big hindering factor. We have a lot of so-called influencers spreading information right and left. The Monjaro phase, the Ozempic phase, the osteoporosis risk, lots of overwhelming information on the net. And I think people, unfortunately, are still relying on this more than relying on facts and talking to endocrinologists and primary care physicians about these concerns.
Thank you, Dr. Wael. Dr. Jalal, I have this question, and again, it seems many people are asking it and for many reasons, and I think you are the right guy to ask. So, transitioning again from Monjaro to Fundayo. So, if you
All right.
can, I know there is no clear guideline about that, but can you at least give us your idea or your practice? For example, patient on
Well,
7.5
it's
Monjaro.
it's a it's a new drug, so I don't have a practice to
Okay,
transition yet.
okay.
Um, so I mean, okay, so this is off-label. All right. So if I have somebody on, let's say, Wegovy, and I'm going to go to Monjaro, typically per label, I start from 2.5, the label. Now, typically what I do, I look at what the patient taking. So if they're taking like 1 or 1.7 milligram, I may let them go directly to 5 milligram dose. in the Monjaro, and I adjust from there. Now, I think on the Fondayo, again, I didn't try yet to switch people. It just become available. So we start in the people on it. So I start with the zero point 0.8 milligram. But if I have somebody, for example, on Monjaro 5, I think it's okay to maybe try to give them 5.5 milligram. Now, saying that, so the third dose, saying that you are going to be surprised how people react. So, and I think this is, you have to understand the label is done because a study is done a certain way. But typically, you're going to have some people that they took a drug and they went to max dose and they're tolerating it. And you switch a new drug and you go to middle dose and they cannot tolerate at all. So I try to take the safe side. So if I switch, for example, from semaglutide to Mounjaro, I'll go to maybe 5, not higher, and I'll give it a month at least to try to see how they react to it. For the Fondayo, I think I'll go to the third dose most likely, as I mentioned. But again, I
Thank,
don't know.
yeah, thank you. As you said, it's a new drug, so but we appreciate your kind knowledge about that. And Dr. Professor Jalal, we have a question regarding Fondayo. Any reason why in the Attain study you kindly showed that there was no arm specified to 14.5 as it was intentionally omitted? Did 14.5 did not show metabolic or weight improvement?
I'm not aware if there's an arm that did, no, no, no. I mean, there's no, I can't remember if there is an extra arm that on the middle dose. So actually, this is the way the study was designed. And actually, the study had a different formulation. So the formulation was different than the one you see now that you buy on the pharmacy. So the 17.2 was 36 milligram. So in the actual trial is a different dose even.
Dr. Wael, I have a question. If you answer it, I'll be grateful. How to stop the feeling of hunger?
How to stop the feeling of hunger? Very good question, Dr. Adil. I'm not sure, actually. I mean, I think, listen, I mean, we have the reasons actually maybe we'll go, why are you hungry? Are you hungry because you are depressed? You're an emotional eater? Are you hungry because of high stress, which we all of us actually emphasize today that, for example, the example that Dr. Jalal mentioned, that lady, she gets home and then she eats because she's tired. So are you tired, emotionally stressed eater, or is there a hormonal dysregulation? I think we should really individualize this question, focus on the individual need of that person and then treat accordingly. Maybe that's probably my best answer. And then if it's hormonal dysregulation, then we have the treatment of the GLPs and the new emerging ones. If it's an emotional eater, we have, or a lifestyle eater, then we need to address this more and then consider pharmacotherapy later.
Sure.
Thank you.
Does
Dr.
that
Wael,
answer
another
your answer?
question.
Are you happy? Did,
Yeah,
did I make you happy, Dr. Adil?
you are always making me happy. Thank
Thank you
you.
very much.
We have a lot of questions. I'll try my best to cover as much as we can. Mashallah, the attendees are more than 800 people. So I'm actually, it's now 1,000 people. So mashallah, we have an excellent number of attendees. Dr. Wael, again, why it is difficult to lose weight after pregnancy and how can we help pregnant ladies post-delivery to lose weight?
Um, Again, the hormonal dysregulation, I wouldn't say it's different. It's different to any other person. And it depends on the person's individual needs. Again, depending on the family and the genetics. I've had many pregnant women who lost their weight very quickly. I think the pregnancy is just a precursor. They probably have eaten and they had um, dysregulation in their eating and their lifestyle habits, their exercise, and then after that, it takes time between the breastfeeding, the prolactin, and also the cortisol and the stress of being a new mom. Um, I wouldn't say it's particularly harder for every woman. I'm not sure Dr. Jalal might have better insight on that, but uh, I've had women, like I said, pregnant who delivered, and then within a few months they went back to their pre-pregnancy weight because that's where their genetic predisposition was. but I guess the same hormonal and the same concept of the hypothalamus dysregulation works for these people.
Uh,
And also the treatment is not contraindicated in post-pregnancy.
Okay. I mean, so when you deliver, I mean, there's many possibilities. I mean, there's a possibility as similar to menopause. You see in menopause, women have a harder time. So there's sudden shift in the hormone, sudden drop in the estrogen, and that could trigger one of the mechanisms. You have to understand it's a very complex system. Typically, you may end up by eating more because you're trying to breastfeed, and sometimes you may eat much more than you should. But typically, you need to be eating 300-400 calories extra, not 1,000 calories extra. You're going to be very stressed. You're not going to be sleeping well. You're going to have a higher cortisol. There's many reasons. Now, this is kind of the possible, uh, likely explanation. And a lot of time when you ask them about the weight gain, there's always something that trigger it. We all have this obesogene. We have these genes that maybe predispose us, and something trigger it. You know, and that could be, some patient will tell you, I got cortisone course for 1 month, and then since then I've been gaining weight and I couldn't lose it. Something changed, and that of course can happen. So typically you see in a woman, could be part of it, but you see it after childbirth, after menopause, there's those changes. That's really hard to understand. And even if you have a woman menopause who start to gain weight, you give her the sex hormone, it's not going to help her lose weight.
Thank you. Dr. Jalal, what do you think about taking metformin for weight management?
Metformin for weight, again, if you look at the diabetes prevention program, so again, this is patient with pre-diabetes, the average weight loss, I think, was about 2.2%. And this is on a dose of 850 twice daily. I mean, you compare that, for example, to orforglipron, and that's 12.4%, tirzepatide 22%, Wegovy 18%, 19%. So it's much weaker. Now there are some data that suggest that high dose metformin may help with weight loss. So this is typically people who take 2,500 milligram or even 3,000, which is not FDA approved dose. That may help, but typically metformin is not a weight loss drug. Some physicians use it as to help with weight maintenance. Again, there's a trial to prove it, no, but I would not use it as weight loss, knowing what I know. I mean, if it's like you have a diabetic patient and their A1C is 12, and I have a drug that reduces it 1%, they go from 12 to 11, or do I use, tirzepatide to drop them 22%? It's like 9 times more effective.
Dr. Jalal, there is a question. Of course, the question of transition from Manjaro to Fondayo, there are tens of them. Everybody
Yeah,
is keen to know the answer. Inshallah,
yeah,
we'll have Dr. Jalal in next few months again, and by
yeah.
that time, his practice will be there a lot with the Fondayo, and then he will give us his experience.
Well,
Dr.
again,
Jalal,
there's the legal answer and non-legal answer. So
yeah,
I give you both.
exactly. Dr. Jalal, any specific maintenance dose to keep the patient on when he reach his ideal weight? So patient took, for example, tirzepatide or Manjaro, he reached his normal BMI. How can he maintain his weight?
So the official answer, if I'm not wrong, 5, 10, 15 milligram. Okay, that's the official answer. So I'll tell you what I do. People generally speaking don't want to take drugs, right? But I explain to them as a chronic condition, not everybody can stop medication. So I, try to be as logical as possible. I use, once they plateau, right, and they're exercising, I try to use the lowest dose that control this extreme hunger and maintain their weight. So mainly for me, what I try to do, the lowest dose I need to maintain them where they are. In some people, it could be 5 milligram. In some patient, could be 7.5. So there is no set number. You know what I'm saying? So if I have a patient who went up to 12.5 or 15 and they plateaued and they said, I don't want to keep taking the drug, then I start gradually. And again, I'll put 3 lines under gradually. Reduce the dose to the lowest dose where they are. So some patient may go to 5 and they tell I no, like I sit on the table and I cannot control my hunger. Then I say, this is too low of a dose for you for maintenance even, and I'll go back again on the dose. So that's what I do. I go really by patient because patients are really different one to one.
Thank you, Dr. Jalal. Dr. Wael, how can we advise the patient who are losing weight how to keep how to prevent them from losing muscles?
Again, very good question. And one of the biggest challenges I have with patients, and one of my issues of having treatment over the counter in Dubai, is that people sometimes think of it as just the easy way out, unfortunately. Exercise, really. You have to eat healthy. And like I tell every patient of mine, this is not an exercise of starvation. This is, you're not taking the GLP-1 to stop eating. You still have to eat healthy. You have to do your job, and your job consists of sleep, eat, and exercise. And when I say about eating, we focus about the quality of the food, the quality of the protein, and the high fiber diet. But then with muscles in particular, yes, it's inevitable to lose a bit of muscle as we lose weight. That's not an issue. The question is not to have significant muscle loss leading to sarcopenia. And usually, in my practice, I have now two patients that I use as a role model for each. They're both the same age group. They both lost around 26% of their body weight. Actually, one of them now is at about 34%. The one who lost the 34% to me is the exact role model. And I tell my patients, who do you think is better? They both achieved their target weight. They both stopped being hypertensive, diabetic, and one of them was a smoker. He stopped smoking. The one who didn't comply with his exercise looks like a 70-year-old frail man. The other one looks much fitter and younger. So it's exercise at least 150 minutes per week and combination of cardio workout and then also resistance. And there's no alternative to that. And it's not about doing them in one day in the gym for 2 hours. It's spreading them over at least 3 to 5 days. And I always tell them it's what fits your life. You don't have to go to the fanciest gym. It doesn't have to be the fanciest machines. It could be dancing, it could be aerobics, it could be collective sports, or it could be doing at home some setups, some push-ups, some squats. So just get the muscles working and pumping.
Thank you, Dr. Wael. Dr. Jalal, we are approaching the end of our Q&A. I'll ask you a question and Dr. Wael a question. Dr. Wael, when do you decide that this patient needs Fondayo or this patient needs Munjaro? So what are the selection criteria for Fondayo specifically?
Uh, I think Dr. Jalal mentioned briefly in his talk about the Fondeo as mostly for people who prefer the oral preparation. But I think really, I mean, again, I'm not going to claim any expertise or practice in Fondeo. It just was released, it's still new. But if I were now to kind of give the choice to patients, it really depends on the target. If someone is already kind of above the 20-25% of overweight obesity, then there's really probably not the best candidate for Foundeo. So I would say weight, starting BMI or starting metabolic numbers, the preference between tablets versus injections, and also in a way the cost. I think cost is a big hindering factor. I keep reminding my patients now who are inquiring about Foundeo that the cost eventually ends up being the same. But at the moment, I would say the biggest two markers are going to be injectables versus target weight. Maybe I would add to a certain extent that I still prefer the injectables for now because I still don't, I'm not sure if we have access to all the doses in the market. I think it's still slowly being distributed, and I'm still reluctant for now, at least for the month of May, to start people on the Foundeo because I think it will add to their stress of ensuring access to the medication.
Thank you, Dr. Wael. Dr. Jalal, last question. When should someone or a lady stop GLP-1 before planning pregnancy? And if she got pregnant while she is on Manjaro or Fundaya, what can happen?
So typically you want to stop 2 months before because for an example, all the injectables have a half-life of 7 days, so really need 3-4 weeks to get out of the system. So typically legally you want to be 2 months before you get pregnant. But there are going to be a lot of circumstances that you tell the patient don't get pregnant, and they do get pregnant because when they lose weight, they're more fertile and they look better. So they tend to be actually more sexually active. There's actually a nice study on teenagers in the US where they did a balloon study and the girls lost weight and they got pregnant. I mean, this is what happened. So you want, in a typical perfect world, to stop it 2 months before. Now, saying that, if a patient gets pregnant, all that you can do is stop the drug because there's nothing you can do. And you can report this to the company, and you should, because what will happen is the company will collect the data post delivery to, I mean, you don't expect really any complication because most of the medication are very similar to the human GLP-1, but irrespectively, the companies will collect the data on any person who got pregnant while taking the medication, and they follow up postpartum on it. So I think, if they get pregnant with it, there's nothing really you can do. You just need to also make sure, because they were taking a strong drug for weight loss, but also it's a glucose lowering drug. I think one other thing you may want to do is make sure that you monitor their glucose. Either they can get a blood glucose machine, and maybe even 1 or 2 days a week. What I would do, I will ask them to check fasting and 1 hour after each meal, because they may actually have pre-diabetes/diabetes that you kind of masked it because you're taking the drug, and you stop the drug, it can go up, you know. So I would think it'll be nice also to monitor that part.
Dr. Wael, Dr. Jalal, Dr. Hisham, thank you so much for participating. I will now
Thank
hand the mic to Dr. Yanal. He has some MCQ questions, and Dr. Yanal, the floor is yours.
So thank you, my wonderful colleagues. It's always enlightening to hear all three of you alongside also Dr. Hisham, who unfortunately could not be with us live. So now we'll just quickly take 5 questions just to test your knowledge. If Fahad, you can share the screen, please. Perfect. So you can vote on which answer you feel is the best, and then we will discuss the answers together. So a patient loses 12% of their body weight over 8 months, but then develops increased hunger and reduced energy expenditure despite continued adherence. So which mechanism best explains this phenomenon? So is it permanent leptin elevation? Is it adaptive thermogenesis with neurohormonal compensation, increased thyroid hormone production, or reduced ghrelin secretion? So it's a pretty challenging question. So try to vote of what you think is the correct answer. I think we'll give 20 seconds, and for the sake of time, we will give the correct answer straight away. All right, so can you show us the poll results? Okay, so 57% of you, more than half, said adaptive thermogenesis, which is actually the correct answer. So what happens is weight loss triggers metabolic adaptation, and this decreases our energy expenditure and increases hunger. And this is normally, as explained by our colleagues, is mediated by decreased leptin, increased ghrelin, and central neurohormonal changes. So next question. So which of the following best explains why obesity is considered a chronic relapsing disease rather than simply excessive caloric intake? And this is a very important question, by the way. So to understand the physiology of this. So A, is it most patients underestimate their calorie consumption? B, is it obesity involves dysregulation of neuroendocrine appetite pathways and metabolic adaptation? C, exercise is ineffective in obesity treatment. And D, BMI directly measures metabolic inflammation. So please cast your vote. I think this is a pretty clear-cut answer. Okay, can you show us the results, Fahad? Okay, so pretty straightforward. 84% of you have voted for that. Of course, obesity is not just a caloric imbalance. The answer is B. It's immunological regulation of appetite, energy balance, and our weight set points. Next question, please. Okay, so which gut-derived hormone is most strongly associated with postprandial satiety and delayed gastric emptying? So is it ghrelin, is it cortisol, GLP-1, or glucagon? And again, all of these can be targets for different medications. So is it ghrelin, cortisol, GLP-1, or glucagon? Okay, can we see the answers, please? Okay, so 54% said GLP-1, which is the correct answer. GLP-1, as we all know, the famous GLP-1 is involved in increased satiety, decreased gastric emptying, and decreased appetite. That's why we have our GLP-1 agonists. Next question, please. A patient with obesity has a normal BMI adjusted LDL level, but elevated ApoB and visceral adiposity. What is the most accurate interpretation? And this is very important, by the way, because of the new hyperlipidemia guidelines. So is it A, cardiovascular risk is likely low due to LDL control? B, is it ApoB elevation may indicate persistent atherogenic particle burden despite acceptable LDL levels? C, visceral fat has minimal cardiometabolic significance? Or D, is ApoB clinically irrelevant when LDL is normal? Okay, can we see the answers? All right, so 76%, more than 3/4 of you gave the correct answer, which is B, which is ApoB elevation may indicate persistent atherogenic particle burden despite acceptable LDL levels. Of course, as we said, this is important in obesity and in our new hyperlipidemia guidelines. I think now we can move on to session 2. Please, we will skip this question, Fahad, for the sake of time, and we can move on to the stage, or we ask our audience to go to the stage and enter session 2, please. I will see you in session 2 to introduce our other speakers.
Is the voice audible now? Is the voice audible now? I'm trying to get some sound, unfortunately. Concerning obesity as a chronic disease. Now it's working. Now it's working. Finally. Okay. So pharmacotherapy versus metabolic surgery. Medical intervention, man with a 22-24% weight loss and excellent CV outcome and requires lifelong adherence, fully reversible upon cessation. Surgical intervention, maximum 25 to 30% weight loss, long-term management strategies. Long-term pharmacotherapy, maintaining benefits and preventing r- regain. The case of continuation. Obesity is a chronic disease. Medication must be continued long term to sustain benefits. Clinical trials consistently show weight regain and loss of cardiometabolic improvements upon discontinuation. WHO recommendation is long-term use benefits as continuous treatment for 6 months or longer. Real-world evidence shows long-term use can maintain 10% or more weight reduction. Individuals' maintenance dosing. Maintenance dose should be balanced efficaciously, healthy balance, health benefits, and tolerability. May not be maximum approved lowest effective dose strategy, intermittent therapy possible, and 20% severe risk cardiovascular reduction in select despite flexible dosing. So withdrawal trial evidence, semaglutide withdrawal, if it is continued, um, 7.9% additional loss and switch to placebo, 6.9% weight regain. Treatment difference minus 14.8%. Okay. So intensification strategies for inadequate response. Stepwise intensification protocol. Dose escalation. Escalate to maximum tolerable dose. Switch medication. If maximum dose ineffective, switch to alternate. Add intensive behavior therapy. Combine medication with structured IBT program. Combination pharmacotherapy, combined different obesity medications, bariatric surgery referral if BMI critical met criteria met and medical therapy fail. IBT with medication synergy, trizepatide with IBT, 24.5% weight loss versus 20.9% with counseling alone. Naltrexone, bupropion plus IBT, 9.3% weight loss. Okay. The trans-theoretical loop, patient, I don't need to lose weight, action, excess empathy, express empathy, explore health values, and provide information naturally. Okay. And if the patient says, I have kept the weight off for a year, then action, revisit relapse prevention, address metabolic adaptation. Patient say, I know I should, but I have failed before. Then action should be develop discrepancy, address past failure as data, build self-efficacy. And if patients say, I bought a gym membership, then need to start set smart goals, identify patient barriers, and establish support system. And if patients say, I have been logging my food and reinforce positive behavior, monitor progress, and refine strategies. So this is how the trans-theoretical loop. So pre-contemplation, maintenance, then action, preparation, and again contemplation. So pre-contemplation, then contemplation, preparation, action, and maintenance. Okay. Behavior modality comparison, motivational interviewing, focus resolving ambivalence, technique, open question, affirmations, reflections, and summarize. Use case, patient is stuck in contemplation. Then cognitive behavior therapy, CBT, the thought, emotion, behavior triangle. Technique cognitive restructuring, challenging all or nothing eating. Use case, patient emotionally eats under stress. And a smart framework will be focused, actionable. The FITTVP dashboard, aerobic, frequency aerobic, 3 to 5 days a week. And this is moderate vigorous and moderate to vigorous and type aerobic and aerobic. Okay. Critical alert, muscle mandate. Without resistance training, 25% of the weight loss during caloric restriction is lean muscle mass. Loss of metabolically active tissue slows resting metabolic rate. Re-guaranteed weight gain. Resistance training with protein 1.2 to 1.6 kg reduce lean mass loss to less than 10%. Sleep weight connection and cortisol cascade. The sleep weight connection, sleep deprivation disturbs cardinal rhythm and neuroendocrine adaptive regulation. As a result, what happens? Hormonal shift, leptin decreases by 18% and ghrelin, which induces hunger, increases by 28%. Oh, so impact is sleeping less than 5 hours per night is associated with a 15% increased risk of obesity. Oh, this is alarming. The bridge metaphor, GLP-1 dose, phase 1, established protein min, minimus and resistance training habits early while adaptive is suppressed, appetite is suppressed, and phase 2, which is in a decline phase, introduce intense CBT to manage returning food noise, increase aerobic volume. And in phase 3, the patient is now fully supported by the scaffolding of high intensified lifestyle interventions. So, requiring behavior and exercise intensively. transforming obesity care through evidence-based practice. Obesity management requires a paradigm shift from short-term weight loss to a chronic disease management. Patient selection based on comprehensive assessment, individualized treatment algorithm, incorporating lifestyle, pharmacotherapy, and surgery, and long-term management strategies are essential for sustainable health goal. So now Dr. Osama Barakat, his presentation, but unfortunately we are not getting the sound. I already raised a question. Again, I'm asking a question. No audio.